very happy to introduce Carter, who will be talking about early changes in passively sensed homestay predict depression symptom improvement during a digital behavioral activation intervention. And we're asking people to do about 5 minutes or so for their talk, and then we'll open it for questions. I'm going to ask everyone to just like unmute, and we'll make it as conversational as possible, because I find that, yeah, it's been fabulous to hear everybody's great insights. All right, take it away.
Great. So I'm a postdoc coming from New York at Columbia. Just first off, a disclosure, some of the co-authors for this talk are employed by and hold equity in Kaxandra Health, which is the company that developed and maintains the app-based intervention I'm going to be talking about. So app-based behavioral activation, or BA, is effective for many people, but not everybody improves. And identifying those people who end up not improving early on is important because it facilitates timely treatment adjustments, which then leads to better resource allocation and treatment outcomes. Measurement-based care is the kind of the gold standard way to identify these people, and assessing early increases in self-reported BA targeted behaviors is one way to do that, as that is a predictor of symptom change later on. However, retrospective self-report measures are rarely administered in real-world clinical context because of concerns about their burdensomeness and validity. And an alternative way to potentially assess these behaviors is through passive smartphone sensing, which addresses these barriers and is already being done by some app-based interventions. So this study aimed to test whether early behavioral changes assessed with passive sensing predict depressive symptom improvement during app-based BA. These were secondary analyses from an RCT testing a app-based BA intervention called Vera. It included 47 young adults with elevated depressive symptoms who were randomized to either a self-guided or a coach-guided version of Vera. The self-guided version was essentially a standalone app, and the coach-guided version was the standalone app, but plus weekly synchronous text messaging conversations with a trained health coach, who also sent kind of smartphone-based nudges to the participants throughout the week. The intervention period lasted 12 weeks, and depressive symptoms were assessed at baseline and after that 12-week period using the THQ-8. Here are the main effectiveness results from that RCT. The average change in depressive symptoms by condition are shown with those thick lines there. And as you can see, on average, depressive symptoms went down, but especially for the coach-guided version compared to the self-guided version. And then those thin lines represent individual participants' change in depressive symptoms over time. And so you can see there's quite a bit of variability. In terms of what the app-based intervention looked like, it provided BA psychoeducation right up front, and it passively assessed behavioral intervention targets, including homestay, so the percentage of the day spent at home, as well as kind of activity-based metrics like time spent walking, stationary, traveling, and sleeping, and then also your bedtime and wake time. So this is what the app interface looks like. It shows daily aggregates of those passively sensed behaviors, and it also presents personalized insights about behaviors that were associated with users' self-reported daily mood. And if you click on one of those insights, it prompts you to reflect on that insight and then offer strategies to modify that behavior, which then theoretically leads to improvements in your mood. We quantified early changes in each passively assessed behavior using a separate multi-level growth model. So this figure sort of illustrates that approach using homestay as an example. So homestay is on the y-axis, and again, that's percentage of the day spent at home. Each participant is a different panel, and each dot is a daily observation. So the percentage of the day that they spent at home on a given day within the first 2 weeks of the intervention. And so each multi-level growth model included a random slope, which represented each participant's average day-to-day change in the behavior of the first 14 days, which you can see are the blue lines there. And we extracted each participant's estimated slope from each model and then tested whether those slopes predicted change in depressive symptoms from pre-intervention to post-intervention. The main finding was that participants who experienced greater early decreases in homestay later had greater reductions in depressive symptoms. So on the x-axis here is the early slope of homestay. So positive values means that your homestay increased over the first 2 weeks, and negative values means that your homestay decreased. And on the y-axis is change in depressive symptoms. And so the people down here are the people whose symptoms decreased the most during the 12-week intervention period. And those people are also, on average, the people who experienced greater decreases in homestay over the first 2 weeks. We also tested the specificity of this effect through sensitivity analyses with various covariates. And we found that it was independent of your initial level of homestays, which was the random intercept. So that suggests that it's specific to change rather than where you started. It was also independent of long-term change in homestays, suggesting that it's specific to early change. And it was also specific or independent of early changes in other passively sensed behaviors, suggesting that it may be specific to early changes in homestay rather than other behaviors. Supporting this specificity, early changes in other behaviors did not predict depressive symptom change. And also none of these associations differed between the self-guided and coach-guided versions. So this is kind of a small sample pilot study, but it provides some preliminary evidence that early changes in passively sensed behaviors might predict symptom change during app-based BA. And importantly, the apps are already collecting these data. And so there aren't any additional feasibility or acceptability concerns regarding data collection, which is not true for self-report data collection. And early changes in homestay might be a viable candidate for an automated early identification tool. So here's an example of what that might look like, where you have early change in homestay and other early predictors of symptom improvement as inputs into a treatment response calculator, and then that can identify people who are at risk of not improving and provide an opportunity to modify treatment early on. There's several limitations, maybe the most noteworthy of which are the small sample size and also the lack of a control group, which means that early decreases in homestay might be predicting symptom reduction rather than treatment response. Lastly, I just want to acknowledge my collaborators and co-authors, Randy Auerbach at Columbia and the folks at Kasana Health. And thank you all very much.
Fantastic. Thank you, Carter, for starting us off. Super interesting work. Let's open it up for questions. Feel free to put it in chat or just unmute yourself to ask Carter a question. Eugenia.
Hi, Carter. Thanks for being the first one, the brave one. This was really, really fascinating. I think it's really interesting to use things that are already being collected as early predictors. So this is fascinating work. I'm wondering what your thoughts are about sociodemographic factors and how they might be impacting this relationship. So I'm thinking specifically about individuals who work from home, maybe underemployed individuals versus those who get out of the house for work. And I know you did control with the random intercept, but I'm wondering if adding more sociodemographic characteristics might impact this.
Yeah, that's an excellent question. And my guess is that it would. This is a very small sample, and I think maybe a proof of concept, but I would be very curious to see, to test that in a much larger sample. And you didn't ask about this, but I think it also gets in at a more complicated level, kind of time varying characteristics that might influence changes in homestay and these other behaviors, like seasonality and things like that. So I think lots of complications to consider.
Thank you.
Other questions?
Hi.
Please, Sarah.
Hi, Carter. Great talk. Super interesting. I thought it was really fascinating at the end when you mentioned that there weren't really differences in the outcomes between self-guided and coach-guided, and wondering if you could speak to why you think that was and implications for scalability of a program like this.
Yeah, of course. So to clarify, there are differences in effectiveness. So the coach-guided version was more effective than the self-guided version, but there were not differences between the two versions in terms of associations between early changes and then later symptom improvement. Which I guess I'm curious what other people think about this, but to me, it's not obvious that there would be if they're both promoting behavioral changes early on. It may be to various extents, but the association between those behavioral changes and then later symptom reduction weren't the same.
Great. Well, thank you so much, Carter. We'll hopefully have time at the end to come back for additional questions, but I'm going to move us on just to make sure we have a chance for everyone, but fantastic. Thank you. If it sounds good to you, I will share screen for you. Hopefully that'll work. And you can just tell me when to move forward on slides. How's that sound?
Sounds good. So hi, everybody. I'm Eva Szigethy. I'm a child psychiatrist and currently I'm the chair of psychiatry at Akron Children's Hospital. The work I'm presenting to you is work that I am still in the process of completing at my 18-year appointment at University of Pittsburgh, UPMC, where I was involved with helping to develop an app, a digital behavioral app, and then in this study, tested in a minority enriched sample of adolescents with depression. So we are just completing the study at the end of this month. So I don't have my randomized controlled trial results for you, but I thought it would be interesting to give you a characterization of the sample and how the study was set up, and then look at our baseline initial measures of just app engagement and looking particularly if there were differences between whites and minorities. So this is a multi-site study that occurred out of 3 children's hospitals in Pittsburgh, Boston Children's, and San Diego, UCSD. And we conducted this in primary care settings where we recruited 16 to 20-year-old patients, and each of the settings we recruited did have embedded therapists in their pediatric clinics. So in these embedded clinics, which we're calling treatment as usual, we were looking, the overall trial was looking at what was the added value, the value add of a cognitive behavioral intervention added to treatment as usual compared to treatment as usual alone. And these patients met criteria for depression both by symptom severity on PHQ, but then also by DSM-4 criteria. And the app itself consists of 32 skills for anxiety and depression. There's both learning components and interactive components. And then there's a coach who texts with users asynchronously. And that coach is there to motivate the participants to use the app, and then also to help them personalize the skills that they're learning. And behind the scenes, the coach has the ability to pull content out of order. So if you're having you're depressed, but you're having an anxious event, they can pull up mindfulness or relaxation audio technique for you to use next. And it's seamless, so the user is not aware that this is happening. App engagement was determined by the number of techniques completed and number of user interactions with the coach. Next. So again, our aim was to characterize, if there was a difference in sort of engagement and usage of the app between our minority adolescents and young adults compared to their white counterparts. And then look at those statistically. Next. So if we look at the overall characterization of the sample, and we have 102 participants who were offered the digital cognitive behavioral therapy intervention. So we're not looking at the control group. 50% white, 18.6% Black, and then the rest were other minorities or unknown. They didn't give us their minority status. And ethnicity, we had 17.6% Hispanic. If we had completed the study, which we did an initial open trial in Pittsburgh, we would not have had this much diversity in our sample. In terms of gender, there was a slight predominance of females, and the mean age was 18 in that 16 to 22-year-old range. And we had a range of insurance type with the majority of patients having commercial insurance. Next. So if you look at our study results, so again, the sample size was 102 who were randomized to this app. 95 downloaded the app. And that was very exciting to us because that rate was much higher than what we
send her
saw
birthday
in our
card this
open
month.
trial.
And I just don't know what to say to Jordan, but I want Jordan to know that because
Oops,
I
let's
imagine that can be
mute
difficult. And
others.
a bunch of adults who knew her mom in a different space. Her father only knew
Mm-hmm.
her mother,
Oh.
around the time they.
Sorry, go ahead.
All right. So, almost 78% completed one technique. And our definition of meaningful engagement based on our earlier open trial was the completion of at least 3 techniques. 65% of these youth completed that 3 technique threshold. The mean number of techniques completed was a little over 5. And what was also very inspiring, again, in this minority enriched population, is that the average message to coaches was about 7. The trial was over a 3-month, so 12-week period of time. Interestingly, most of the app usage occurred in that first month or so, maybe first 6 weeks. We looked at baseline characteristics across the sample, and almost half of the patients were seeing a behavioral therapist at baseline, and a little over half, almost 58%, were on a psychotropic medication. Now, I didn't want to clutter the slide, nor did I want to go over my 5 minutes of allotted time. So I'm not showing you the differences between the whites and minorities. What I can tell you is there was no statistical or clinical difference in terms of their app usage in any of these categories. And the only thing that was slightly higher in the whites compared to the minority group is antidepressant use at baseline. It was the whites were at sort of 58%, and the minorities were in the low 50%. But even that wasn't a huge difference. And so, and the mean PHQ score at baseline was 15. So also that, we can tolerate a pretty moderately high level of depression severity and still find that there's this high engagement in these depressed youth. Next. So in conclusion, again, there really were not differences in users. And I think this is so important when we're talking about equity and making sure that apps are culturally sensitive, as well as available to all our patients. And so I do think that these early findings support the utility of a digital behavioral tool for a diverse group of adolescents and young adults with depression. And we'll be going on and sort of testing, different digital tools now in my role at Akron Children's Hospital in younger adolescents, because I think they could really benefit as well. Thank you. Next slide on my thank you slide. So again, when you have a 3-site study that you're running, you have to thank a lot of investigators and staff. We had foundation funding for this study of just over $1 million. And then this study was run by UPMC Health Plan. The digital app, and I think this is apropos for this meeting to end, it actually was the digital app developed by a company that no longer exists, Lantern. They actually developed their app out of Stanford, and then UPMC bought a license, and we then further personalized it for the use of our patients across UPMC, so children and adults. And then the last number of years, it actually is an app that is now being run by our UPMC Health Plan, so our own insurance company, and they provide it as a wellness tool for all their members. Our study was not only the UPMC Health Plan members, but really we were able to use it for the purpose of the study. So thank you.
Great. Thank you so much, Eva, for sharing your fantastic work. Really appreciate it. Let's see. We are a little tight on time, but maybe we can take one quick question for Eva before we move on. Curious sort of major adaptations you're planning for the rollout at Akron with slightly different age group?
I think that a lot of it is going to be in how do you sell this to the younger kids to use.
Yeah.
So both at the level of the pediatrician's endorsement, and I think obviously we now have to get parental approval. And again, whether we do that in a formal consenting process or just, again, making sure that the parents understand that this is, used for a clinical purpose. This is not connecting their child to social media, especially with what we just saw from the Surgeon General, and that, that this is a way that kids actually prefer to connect.
Great, thank you. Well, thank you so much. I'm going to move us on in the interest of time, but please add other questions for Eva into the chat. And very excited to introduce Sarah now, who's going to talk to us about global engagement and outcomes from an employer-sponsored digital mental health platform, a retrospective study.
Awesome, thank you. And can everyone see my slides? Yes, okay, great. Thank you so much, everyone, for your time today. My name is Dr. Sarah Sagwe-Henson. I'm a health psychologist and a research scientist at Modern Health. That is a company where we're offering comprehensive mental health benefits to employees around the world. And I'm very excited to share some data on our global engagement and clinical outcomes today. As a disclosure, the platform we studied here is a commercial product, and all the authors are employed by Modern Health and receive salary and stock options. So I wanted to start today by talking about the global mental health treatment gap. And this really refers to the large discrepancy between the people who need mental health treatment and those who are actually receiving it. And so in developed countries, this gap is around 35 to 50% of people who are left without care. And in low and middle income countries, that number is around 80%. So there are a lot of barriers contributing here, as you can imagine. So it's important, I think, to note that addressing this gap needs to happen by scaling up access to evidence-based mental health services, which is what I'll be talking more about today, and also through prevention by addressing social, economic, and political determinants of health. And I just think that's really important to note here. Today, though, like I said, I'll be focusing on the former and taking a look at whether access to a scalable digital mental health service offered through employers is engaging and clinically effective globally. So this was a retrospective observational study where we examined engagement and clinical outcomes of a digital mental health platform that was employer sponsored and offered a lot of different services across international regions. The study was a chart review of over 33,000 employees who enrolled in the web and mobile-based application. They were around 34 years old on average, and about 40% of them identified as female. They enrolled in the application during the study timeframe, and they needed to have completed at least 2 clinical assessments listed here, at least 30 days apart in their preferred language. So we looked at well-being, depression, anxiety, and burnout. This is the global distribution of participants, and 1 in 4 employees eligible to use this platform are outside of the US. So this really mirrors that distribution in our commercial data here. In this study, about 73% of the participants were living in the United States, and about 27% of them were living outside the United States. Employees learn about these services through their employer. They register on the app or website, and then they indicate their preferred language, their care preferences, and their baseline clinical symptoms. And all of this is put together to give them a care recommendation to work with a licensed therapist, a certified coach, or use group psychoeducation sessions or self-guided digital resources. And importantly, all of the care here was localized and culturally centered. And so at the time of the study, the entire app and all of the digital resources were available in 13 different languages. High quality therapists and coaches provided evidence-based sessions in over 60 countries and more than 55 languages. And all aspects of care, including provider matching, digital resources, group support, and even provider training, were built to be culturally centered. And we have a global inclusion council of providers from around the world review care delivery best practices for cultural nuance. For our analyses, we first looked descriptively at engagement across each region, and then we used regression models to test whether engagement across all regions was associated with changes in mental health over time and whether this was independent of baseline scores, different demographics, region, and time. Okay, so let's get into some of the results. Here we're looking at overall engagement rates by global region. So the slice in the lightest blue represents no engagement. So what you can see is that across all global regions, rates of connecting with mental health care and using at least one service was very high. It was a little over 86% on average. And then the average percent of people using 2 or more activities, which would be the darkest slices up here, was almost 50%, which is quite high. And then when looking at the association between engagement and clinical outcomes across all regions, we saw higher self-guided digital engagement, meaning 6 or more activities here, was associated with increased well-being and lower odds of depression, so a 21% reduction here. And we also saw a 15% reduction in the odds of anxiety and an 11% reduction in the odds of reporting clinically significant burnout at follow-up. We also found there was a dose-response relationship between higher one-on-one session engagement, and this is for both coaching and therapy, and improved outcomes, except for burnout here. And so the highest increase in well-being and the lowest odds of depression and anxiety were among people using 9 or more sessions. And so, for example, looking at depression, people completing 1 to 2 sessions were 8% less likely to have depression after using this follow-up, and completing 9 or more sessions cut the risk of depression in half. The biggest strength of this study is definitely the use of global real-world data. These data are really hard to come by in digital health, and it's really important that if you're building a product for and serving a global population, that you have the data to back that up and you have the data to see whether people from around the world are using it and whether they're benefiting from it. But of course, this is just an initial first step in taking a look at this. A few of the limitations are that we had small subsamples and we pooled people by region, which likely masked patterns for individual countries here. So getting more data in each region is going to be really important. And also employees self-selected into signing up for this platform, which may limit generalizability. It is really important, though, to have internationally accessible and localized mental health services when it comes to improving population health. And so the platform we studied here we found that it was really good at connecting people globally with services that were clinically effective. And it really highlights that having one place for people to access different types of culturally centered services may fill that gap or may work towards filling that gap in global mental health treatment and support employers with workers across the world. And so thank you to all the participants in this study, our providers, our team at Modern Health, and my co-authors. I hope you're all having a great time at this conference. It's one of my favorites. And so thank you so much for your time today.
Fantastic. Thank you so much, Sarah. Super interesting. Really cool to see this data. Let me open it up for questions.
I have one.
Please jump in.
This is fascinating. It's really, it jives really well with what I'm going to present in a second, because we're also focused on real world data. I do wonder, have you been able to compare at all to minimal coaching and more self-led modules in terms of the treatment duration in itself? Because what we're finding is that really the therapist support seems to be the primary factor for dropout, unless I misinterpreted.
Yeah, that's super interesting. In this study, no, we didn't sort of pit dosing against each other in terms of like, is there a dosage of self-guided care that would match up to a certain dose of provider-led care? Would be super interesting to look at. We have some other data that we've seen where people who are engaged with a coach or therapist are using twice as many digital resources as people who aren't in provider-led care, which starts
That's
to get at some
interesting.
of that blended care and how they work together. But
And
that's a really
adherence.
great point. Yeah, that's a really great point.
Yeah.
Thank you.
Fantastic. Please keep asking questions there. Maybe we've got one more that's in chat if you want to take Lou's question, Sarah, and then we'll we have 2 more presenters, so we'll move on just to make sure everyone gets a chance.
So answer it now or answer it in the chat?
Yeah, go for it. Go for it if you can do it.
Okay, great.
Sorry.
Thank you so much for your question, Lou. Yes, about the sample, I missed it. Did you mention that over 80% of the clients came from the US? Was there interesting differences in terms of US versus out of US sample? Yeah, there were some interesting differences in engagement. And so we actually have another paper where we're diving into that a little bit more, where we saw that people in the United States were much more likely to engage in one-on-one provider-led care than people outside the United States. And those outside the US were more likely to use self-guided digital care. And we also saw some differences in age that were interesting, where older adults across regions were actually more likely to use self-guided digital care, and younger people were more likely to use one-on-one care. So yeah, thank you so much for that question, and thanks for your time.
Super interesting. Sarah, if you have a link to that, feel free to drop it into chat for folks, but really interesting. Wonderful. Thank you. Well, I'm happy to introduce Jenny. Am I pronouncing your name correctly?
Jenny. That Jenny is fine.
Okay. Very happy to introduce Jenny to talk about leveraging linked Ontario's health administrative data to characterize ICBT recipients compared to those receiving one-on-one CBT and routine care.
Perfect. Someone please give me a thumbs up when you can see my screen. Amazing and perfect. Okay, thanks for the introduction, and thank you, Sarah, for your study, because we're on really the same page here. So you saved me some background slides. First, I'd like to acknowledge my thesis committee listed on this slide, really great world-renowned researchers, as well as my funding by the Canadian Institute for Health Research Canada Graduate Scholarship. So let's get to it. I'm sure we've heard all over this conference really the promise of virtual mental health intervention for meeting increasing service demands. And really the point of what we looked at here is the self-guided mode of treatment that allows us the scalability that we're looking for to meet the access demands. So for those of you outside of Canada, we do see, similarly to what's been said today, about 30% of individuals reporting unmet mental health care needs. So really we want to tackle that. And in 2020, the province of Ontario launched internet-delivered cognitive behavioral therapy, or ICBT, and it's publicly funded, self-led online modules with minimal and asynchronous therapist support. So those are check-ins on an ad hoc basis that are quite rare. And because this is provincially funded by the government, we were able to leverage health administrative data linkage to compare this to a real world standard care CBT program, which is quite rare to do in the real world. So most of these studies come from randomized control trials, but we were able to do it in routine care. And the goal of our study was to look at the reach and treatment completion. So who is more likely to get standard care versus ICBT, and who is more likely to complete their treatment when it's delivered in routine care. So as I mentioned, we did quite a bit of data linkage, and we compared ICBT, which is the self-led asynchronous online modules, to standard care. So those are therapist-guided, scheduled, fully synchronous one-on-one CBT sessions. From these data sets, we looked at treatment duration, exit disposition, so whether treatment was completed, as well as at anxiety and depression symptoms using PHQ-9 and GAT-7. We linked it to sociodemographic characteristics, so sex, age, rural dwelling, and neighborhood income were obtained. And then we also obtained health service use at the 1 year preceding treatment initiation. So we looked at the outpatient physician visits for mental health, so people visiting psychiatrists and primary care providers, as well as acute care. So those are emergency department visits and hospitalizations in the 1 year prior to treatment. And we also looked at medical and psychosocial comorbidities. So we had 167 individuals who received self-led ICBT via a pilot program and 300 individuals receiving standard therapist-guided CBT at the Center for Addiction and Mental Health between 2020 and 2021. So our first research question, my slide isn't moving. Okay, first we asked which individuals are more likely to receive which modality. You can see on the slide the demographic characteristics. And what we did is we conducted multivariable logistic regression that adjusted for these sociodemographic characteristics. So we adjusted for age, sex, neighborhood income, comorbidities, baseline symptoms, and prior mental health service use. What we found was that older individuals, those with lower baseline anxiety, and those with a prior mental health related acute care visit, so that's emerge or hospitalization, were slightly more likely to be in the ICBT group or the self-led online group. This was statistically significant, but not clinically significant. So the differences were quite minimal. The second thing we asked is, once you're in, who is more likely to complete treatment? So we use treatment disposition to determine who completed their treatment program. And again, you can see the characteristics on the slide, and we conducted multivariable logistic regressions with all the same characteristics, but now our main exposure was treatment modality. As you can see here, 314 individuals in our cohort completed their treatment, so just a little over 2/3. But of those, about 30% were in the self-led ICBT group. And unsurprisingly, those who were likely to complete their treatment also had a longer treatment duration. So that kind of relates to my earlier question. What we found from the logistic regression was that the self-led ICBT clients had 51% lesser odds of completing their treatment program compared to those who received the standard one-on-one therapist guided CBT. Before I jump to conclusions, I want to make sure we cover the limitations. So using health administrative data has some inherent limitations. So for example, we were missing some important covariates, such as social support availability, that may impact the relationship between both reach and adherence. So that's important to note. The other thing to note is we are unable to see in our data services that are covered outside of Ontario's public health insurance. So those would be your out-of-pocket services and private providers such as psychologists, social workers, anything covered by employers, unfortunately is unavailable in our data. So we're unable to tell if individuals were receiving that concurrently prior to or following their treatment. The other thing to note is that our pilot study did overlap with the COVID-19 pandemic. So of course, we want to keep doing these studies at less unprecedented times. And I also want to highlight, because this is a real world study, there were of course potential selection biases, both by the clients themselves and by referring clinicians. But that is the nature of the real world study. To reiterate, this is really the first study in Canada that used health administrative data linkage to examine and compare ICBT to standard care in routine practice. And what we found was that the clinical and demographic differences between the two groups were minimal. However, once in treatment, treatment completion was much lower in the self-led ICBT modality. And this really suggests a need for us to expand the reach and really increase efforts to prevent loss to follow-up in self-led modalities so that we can scale them better and have them impact the access gaps. Thank you.
Fantastic. Super interesting work, Jenny. Let's open it up for questions. I'm going to selfishly start us off here. I'm super curious, having grown up in Canada and now living in the States, whether you think you would get very similar results in the States or how you think the sort of differences in healthcare systems may be influencing the patterns you're seeing.
I think that that's a really great question. And I think the challenge in comparing between the US and Canada is really in the health coverage. So what we're seeing that Canada likes to do when we are funding any type of pilot programs by the government, they tend to be quite small, and the pilot programs tend to not scale and spread beyond their initial pilot implementation. So I think that there's a lot of room for qualitative research as well to really figure out how to implement these programs effectively. Whereas in the US, I feel like, again, the previous presentation was a really great example of really well-led implementations that are coming from the public sector and through employer-based coverage that are able to scale and spread in a way that's a little quicker and more efficient. Yeah.
Great comment. We have time for maybe one more quick question if it's a short one. Fantastic. Well, please, as people have been doing, keep adding your questions to chat to continue the conversation that way. Thank you so much, Jenny. Super interesting. I'm very happy to introduce our final presenter. Amanda will be talking about using tailored digital CBT interventions to treat anxiety and depression.
Realizing I didn't unmute myself. Can everyone see my screen?
You're good.
Excellent. Thank you. Thanks for having me today. So first and foremost, want to make sure we review our disclosures. Both myself and our other authors are equity holders of NeuroFlow, which is a behavioral health healthcare technology company which sponsored the research today. But let's get right in. So not surprisingly to anyone, in this session, there is a mental health crisis. The number of individuals that we are identifying with having mental health needs is growing, and the acuity of those patients we're seeking to care for is increasing. And this combination is resulting in, combined with high rates of medical comorbidities, really resulting in an economic crisis, not just a mental health crisis. And yet we find ourselves in the United States with, despite this need, large portions of the country existing in what we call mental health service area deserts, where mental health professionals are leaving the industry faster than they can be replaced. And we find ourselves in a scenario where there are more people who need services than we have the capacity to serve. And that has its own cascading impacts. And so as a result, those of us in healthcare are really forced to find innovative ways to support our patient populations in a way that's both evidence-based and cost-effective and allows patients to get the care that they need when they need it in the way that they seek to engage. This creates more access and opportunity, both for those who are seeking direct care team interactions and those that are not. The idea is really we want to create a larger toolbox, recognizing that patients have differing ways of engaging with services, and we need to expand that via multiple avenues of intervention. And digital behavioral health platforms are really an opportunity to do that. They provide location agnostic ways to deliver evidence-based healthcare in a way that for those that are uninterested or unwilling to engage in traditional services, while simultaneously ensuring that care teams get treatment insights that they need to provide ongoing care and support their patients. And that's a really important component of what we're talking about today. It's that closed feedback loop so that interactions with a digital behavioral health platform aren't happening outside of the interventionists and the care teams. So we wanted to evaluate the utilization of a digital behavioral health platform as a delivery mechanism for behavioral health interventions. NeuroFlow, which is the company that I work for, in partnership with Magellan Behavioral Health, which is a behavioral health payer here in the United States, sought to evaluate the link between digital cognitive behavioral therapy engagement using a digital behavioral health platform and patient outcomes associated with anxiety and depression. We retrospectively queried pre-intervention GAD-7 and PHQs completed in the NeuroFlow digital platform for the study cohorts, which consisted of adult members covered by Magellan Behavioral Health and who had access to the NeuroFlow platform and had completed those initial assessments with a score of 5 or greater. These individuals were automatically recommended either Fear Fighter, the DCBT module for anxiety, or Mood Calmer, the DCBT module for depression within the NeuroFlow application. These two DCBT curriculums had been utilized in previous studies and are validated as DCBT curriculums. And importantly, that's important for this particular study is that we weren't seeking to validate the DCBT modules themselves, more so the use of a digital behavioral health platform as the delivery mechanism. And we felt like this was important because digital behavioral health platforms really do rely on design, behavioral economics, and gamification to drive engagement. And our retrospective study then was well suited to kind of capture real world treatment outcome relationships, as opposed to other scenarios we were seeking to validate the modules themselves. So participants were free to complete as much of the DCBT content as they liked. Fear Fighter consists of 9 45-minute sessions designed to help participants engage and manage generalized anxiety, panic attacks, and phobias, whereas Mood Calmer consists of 4 30-minute sessions that were designed to help manage unhelpful automatic thoughts. And our hypothesis was that greater engagement with the DCBT content would predict significant reductions in anxiety and depression severity. And we sought to evaluate how starting severity would also impact these outcomes. Unsurprisingly, we know that DCBT works. So there was a significant pre-post assessment improvement in both the anxiety and depression cohorts. We then evaluated engagement, comparing those who completed at least 75% of the Mood Calmer and Fear Fighter curriculums, and those who completed less than 75%. We identified that highly engaged participants, those who completed 75% or more, saw a 41% reduction in GAD-7 scores compared to those who engaged less in that Fear Fighter module. In the depression cohort, highly engaged participants saw a 24% reduction in PHQ scores compared to their peers. While the between group difference wasn't significant, we did see trending in the expected direction, meaning that those with greater engagement did see greater improvement. And then finally, we evaluated the hypothesis that initial symptom severity would predict enhanced outcomes. We identified that initial severity was a significant predictor of outcomes for the anxiety cohort, where severely anxious patients saw the greatest benefits. In the depression cohort, a non-significant trend emerged, but this was less, severity had less of an impact on outcomes. And importantly, our findings highlight that the potential for digital behavioral health administered DCBT to augment existing treatments and underscore the potential for digital behavioral health tools to the extent that we can create access beyond traditional practice and really provides resources to help patients where they're at and provides more of an opportunity to engage over time. And finally, we're really excited to say that this particular paper is now available in open access, or will be in the coming weeks, within the Journal of Innovations in Digital Health Diagnostics and Biomarkers. All right, and thank you so much.
Thank you, Amanda. That's fantastic. Yeah, really exciting work. We are at 2 o'clock, so the time has sped by. I will keep the room open a couple of minutes for people who want to sneak a question in for Amanda, either unmuting or add it to chat. For those who need to sign off, thank you so much for joining, and a huge thanks to our fabulous presenters for just, a wonderful lineup of talks. So as I said, I'll keep it open a couple of minutes for people.